This conference will now be recorded.
Okay, we are going today to discuss the guideline of chickenpox in pregnancy according to Rcbi guidelines. And I'm going to try to illustrate what's differences between this guideline and the RCOG recommendations. So let's start. Bismillah. If there is any questions, you can drop it in the chat box or we can discuss after we finish. Okay. So let's start about some facts regarding the chickenpox virus or Varicella Zoster virus. It's a DNA virus and it's of a herpes family. I just dropped these facts here because you know your exam will be a single best answer and you may find one of these in between the other lines of the clinical cases. So you just go through this and everything will be fine. Okay, so it's a DNA virus. It's related to the herpes family and it's a highly infectious or highly contagious virus. Usually the herpes virus is transmitted by respiratory droplets or by direct contact with infected person, especially with the vesical fluid of rash. Or indirectly through the fomites he used or something. So the mode of infection is a respiratory droplets, direct contact with the infected person, or indirectly via fomites. Here the incubation period and the infectivity period, and this is repeated questions. The incubation period for this virus is 1 to 3 weeks. Okay, you will find it maybe they stated as 7 to 21 days, and that's fine also. The infectivity period, which is very important one, and you have to know by heart, is 2 days or 48 hours before the rash appears and until the vesicles crust over. And usually the vesicles takes about 5 days to crust over. Until this period, the patient is infectious. After this, the infectivity period goes. Okay. We have two types of infection with chickenpox, which first one is the primary infection. And we mean with primary infection, the person who takes the infection for first time. Okay, and as you know, chickenpox is a common childhood disease, and the mortality rate in the childhood it's very minimal, but when it comes to adult and especially pregnant ladies, the mortality and morbidity become much higher. Okay, here we come. We have some numbers here, and here comes the difference between the Rcbi guidelines and the RCOG guidelines. Because they are different communities, they have their own studies. Something happens in common in between, and something is different. But you will not find the differences, you know, that not pretty much, just small percentage. That's it. Okay, so in Ireland, they stated that over 90% of the antenatal population in UK, Ireland, both here are seropositive, but you will find it in the UK, in the GTG, they stated as 85, maybe because the GTG is more recent than this one. So it's in UK, it's stated that 85%, here they stated 90% are seropositive. Seropositive means those people are immune. They have the IgG antibody. Okay. It's uncommon, as we told in pregnancy, it's uncommon for adults and uncommon in pregnant ladies, but it carries higher morbidity and higher mortality rate. Okay, and especially in pregnant women, it's higher than the normal adult. Also, we have to know that all women come from tropical and subtropical backgrounds, like Egypt, like India. These areas are more susceptible to develop the infection because the immunity rate in these communities is not as much high as here in the European countries. So you have to keep in mind, if you have in your case stated that the woman comes from tropical or subtropical area, you bear in mind that she's more susceptible, and you have to take your precaution here with this woman. As they said here in the Rcbi guideline, this disease complicates 3 in every 1,000 pregnancies. In the GTG, you'll find it's 1 in 200, and this is pretty different. So you should keep this in mind. In the Rcbi, they said that it's 3 in 1,000 pregnancies. In UK, 1 in 2,000. Okay, so how this primary infection will be manifested on the patient? The patient will be presented by fever, malaise, and the characteristic thing here is the rash. It's maculopapular rash, vesicular, and appears in groups. You'll find it described like this. So it's very characteristic for the chickenpox. So what about the secondary infection? We said we have 2 types of infection. Primary, the person who's taking infection for the first time, and we have secondary infection or reactivation. After the person takes the infection of the herpes zoster, the virus remains dormant, not active, in the sensory nerve root ganglia. And once this person is immunocompromised, and we all know that pregnancy alters the immunity of the pregnant ladies, that's why the pregnant ladies are more susceptible for the infection. Okay, this virus flourish once again, and it will start to cause disease, but this time it has very characteristic distribution, which is dermatomal distribution. Usually it affects the nerve distribution, maybe the ophthalmic nerve distribution, maybe the thoracic nerve distributions. Okay, but you should bear in mind that the exposed type of shingles is the infective one. So when the woman comes to you and she says, I have contact with some person who diagnosed that he have or she have shingles, you have to ask, where is the site? Is it exposed one? Is it ophthalmic, somewhere exposed area, or it's covered area like thoracic nerve distribution? This is one of characteristic points you have to ask when the woman come to you and said, I have exposed to someone with shingles. Okay, so now we know about primary infection and its characteristic, the secondary infection and its characteristic, and it's a reactivation. It's not an active infection. Here, I would like to tell you a few words about the varicella vaccine, or as they stated in the Rcbi guideline, it's a Varavax. It's by name. They said it by name. And we all know that the varicella vaccine is a live attenuated vaccine. So we can't give it during pregnancy. So the woman who comes to you before pregnancy and she wants to check her immune status, and you found that she's not immune for varicella, you are going to give her the vaccine. If she agree about this, okay, it will be given on 2 separate doses, 4 to 8 weeks apart. And you have to instruct the woman to avoid pregnancy for 1 month after the last dose. She will take 2 doses and she have to avoid for 1 month after the last dose, because it may lead to post vaccination rash or infection. It's reported with some cases, so it's better to avoid pregnancy for 1 month. Okay, so we avoid contact with other pregnant women if post-vaccination rash occurs. Reported that some cases who took vaccination, they may report subclinical infection or post-vaccination rash, so she become infective to other pregnant women. So she have to avoid contact with pregnant women if she developed post-vaccination rash. Okay, so what happens if the woman took the vaccine while she's pregnant and she doesn't know? This is very rare to happen, to give such a vaccine to a woman and you don't know she's pregnant. But if happen, they have showed that in the guideline there is no cases of fetal varicella syndrome, okay, reported after inadvertent exposure to the vaccine. And there is no increased risk of fetal abnormality has been detected. So even it happens, there is no cases has been reported, but it's better to avoid that because you don't know. It may happen, okay? Okay. The benefits of the vaccine is that it's not very pretty much a point, but you have to take in mind that immunity from the vaccine may persist up to 20 years. 20 years after the vaccination, it gives immunity, okay? And the rate of primary infection in the general population has been fallen by 90%, okay? And the mortality related to this condition is decreased by 2/3 after the vaccination. So the vaccine is very important. If you have the chance to immunize the pregnant woman, it's very good. But if you have no chance, we will see what we are going to do to manage this disease if happen. Okay. If you know that one patient is not immunized and she catch infection or she didn't catch infection, but you know during pregnancy she's not immune to varicella zoster by examination or whatever happened, you have to discuss with her about the postpartum vaccination. Postpartum vaccination, you have to consider and discuss with the woman. You have to offer it for her, okay? And you have to illustrate that if she took the postpartum vaccination, this thing will not deprive her from a breastfeeding her child, because some women are hesitant about taking the vaccine. Does it may cause disease to my child? It will affect me? Nothing. It's very safe to breastfeed your baby. Okay. So now we finished the key facts about the virus and the vaccination. We will go to manage our patient. I prefer to see it as there is a case coming to my clinic to have a sequence in my mind. So what if you have a patient, she walked to your clinic and she came for a counseling before pregnancy? What are you going to do for her? If this patient, you are talking with her and she's concerned about this infection or whatever, or you are just taking history for pre-pregnancy counseling, if this patient's having solid past history of chickenpox, this is a very good predictive, okay, that she have serum varicella antibody and she's immune, okay? But unfortunately, this solid evidence is less reliable on those patients who came, as I told you, from tropical climates and subtropicals. So you can't trust this history 100% on those kind of people. But if she's a European, she's from UK, Ireland, this cold weather, those people, if they have solid past history of the infection, it's mostly reliable, 95 to 99 predictive of the presence of the serum varicella antibodies. If she's tropical or subtropical, Egypt, India, Bangladesh, like this, you may have to doubt she have or not. If she doesn't, if she's not pretty sure about that she had the infection by name, so you can't rely on it. Okay, so it's better if you have a chance to test the serum for varicella antibody for those who have no history or uncertain history of previous infection, like tropical or subtropical. You are not going to do the test for every and each woman. You have to do this for people who have no history or uncertain history of previous infection, or if she's from tropical or subtropical area. If she's seronegative, she doesn't have the infection, and she's here with you for pre-pregnancy counseling, she's not pregnant yet, you can offer the vaccination for her. Okay, so the next step, what if the woman came to you while she's pregnant, okay, and she doesn't have any history of varicella? What are you going to do for her? She doesn't have the infection. She's at booking and you're taking history from her, and you're just arranging her antenatal visits like this. For those women, usually they take serum sample, booking serum sample. In Ireland, in some places with arrangement with the labs, they do booking serum testing to check, but it's not the rule there. In UK, they don't do this. Basically, they just keep the sample, the serum sample, just in case something happen. You will go back. They will go back for this sample. In Ireland, in some places yes, some places no, but it's recommended only for patients who are uncertain of history, if she doesn't know she had the infection before or not, or if she's from tropical or subtropical area. So if you detect it at the booking, you just reassure the patient, whatever, if she had been exposed to the infection, it's fine, reassure she had the antibodies which will defend her. If she's not, if she's seronegative, so you can't give her the vaccine, we agreed about this, it's live attenuated one, but you have to advise her to avoid contact with any suspected case of varicella or shingles. This what happens at the booking visit. Okay, why we are concerned about the chickenpox infection during pregnancy? As I told you, it carries higher morbidity and higher mortality than the other population, and unfortunately during pregnancy serious complications may happen, which is number one is the pneumonia. And the Rcbi guidelines stated the number of cases is 10 to 14%, okay, and the severity increases later in pregnancy. The more the woman is near the term, the more the complication severe will be. In the UK guideline, they stated, frankly, it's 10%. So you just say here they give a range 10 to 14, and here it's 10. Here it is the same, but just few differences to spot. Okay, after pneumonia, we have hepatitis, we have encephalitis, up to death. Unfortunately, death from chickenpox in pregnant ladies is more than the normal adult, but the reported cases is very few, and they stated that in the guideline in Ireland, they didn't spot any deaths from the varicella zoster, pneumonia, or complications in their community, and that's a good thing, but it can lead to death if this severe complication happens, not managed well, it may lead to death. Okay, this is the maternal implication. This is what could happen to the mother from mild disease, rash, fever, malaise, up to pneumonia, hepatitis, encephalitis, and death. So what's going to happen to the newborn or to the fetus? Okay, here's the complicated part, and we have much numbers here to focus on. Okay, first thing, we have the fetal implications, or as you know, they found that the miscarriage rate or the spontaneous miscarriage risk is not increased if the chickenpox happen in the first trimester. It's not increased than the other population. It's the same. The risk is the same. It doesn't cause abortion. If the patient comes to you, does it will affect my baby? I'm going to abort, but my baby will die? No, you have to say it's the risk. You don't say no, but you say it's not. The studies show that it's not increased than the normal population. So your disease or the chickenpox, it will not lead to miscarriage, by a higher percentage other than the other population. Okay, and here we go for the fetal varicella syndrome. The percentage is very important. It's 1%. The fetal varicella syndrome, it happens in 1% of those fetus whose mother have the infection during pregnancy. So what's characterized this fetal varicella syndrome? The clinical features is that, and these features what we are going to check on the ultrasound scanning while we are scanning for fetal varicella syndrome. The baby may have skin scarring in dermatomal distribution, and we will say why in dermatomal distribution, why not just rash. Okay, it may have eye defects, microphthalmia, chorioretinitis, or cataracts, and they may have limb hypoplasia, also some neurological abnormalities because this virus affects the nerve root, maybe cortical atrophy, mental retardation, microcephaly, and some dysfunction of the bowel and the bladder sphincters. Okay, as I told you, why skin scarring? Why these neurological abnormalities? Because the fetal varicella syndrome, it happens due to reactivation of the virus in utero. Okay, and it happens to minority of infected fetus. Not every fetus have exposed to this infection will progress to fetal varicella syndrome. Only 1%. Okay. Okay, the fetal varicella syndrome has been reported to complicate maternal chickenpox that occur as early as 3 weeks up to 28 weeks of gestation, and there is no cases reported after 28 weeks. So if the fetus is going to have this varicella infection, it will be between 3 weeks up to 28 weeks. Okay, and the risk appears to be lower in the first trimester. So if the woman have the varicella infection in the first trimester, first 12 weeks, so the varicella syndrome can happen because we are above 3 weeks, but it's very minimal to happen. According to the GTG, it's 0.4%, okay, in the first trimester, and it's 2% between 13 to 20 weeks. And they stated that the mortality rate from this condition, if happens, is high. So not all babies are going to survive the fetal varicella syndrome. So to summarize the points we have to know about the fetal varicella syndrome: number 1, it happens due to reactivation of herpes zoster in utero. It occurs in minority of cases, 1%. It has certain clinical features: skin scarring in dermatomal distribution, eye defects, nerve defects, and limb hypoplasia. And the most important things you have to know here is it happens if the baby, it happens to the baby between 3 weeks and 28 weeks. No cases reported after 28 weeks, and it appears to be very low in the first trimester, the first 12 weeks. And here is the percentage. This percentage is according to the GTG. It's not the RCPI ones. Okay, so I'm writing UK near it. So that's what you have to know about the varicella syndrome. How to diagnose this? It's easy. We have defects, so we can check by ultrasound. You go for ultrasound scanning. And here is one thing to know about the ultrasound scan. The woman will come to say, I have infection. Okay, she's confirmed varicella infection, but you are not going to do ultrasound for her right away. You have to wait for at least 5 weeks time lag. Why? Because the study shows that all ultrasounds done after 4 weeks or before 4 weeks past of infection, okay, it show nothing. So you have to wait for at least 5 weeks of maternal infection, okay, to show anything in the ultrasound. There's another thing, I don't know if it's also stated in the GTG or not, but the RCPI guideline talked about the PCR. They give some details about the PCR diagnosis. You can aid the diagnosis, and they talked about its sensitivity and specificity. So we have to follow them. They said that other than the ultrasound, you can do fetal varicella virus DNA, okay, to be detected in the amniotic fluid by the PCR. Okay, and they stated that the PCR having high sensitivity. High sensitivity means it spot the true positive case. So if the test said it's positive, so it's true positive case. Okay, but it have low specificity. Low specificity means that the ability of test to say this baby will not have varicella in the future, or it may say the baby have no varicella but he may develop, okay, is low. Sensitivity is to spot the true positive. Specificity is to spot the true negative. Low specificity means low ability to spot the true negative cases. So this you have to keep in mind because they like sensitivity and specificity questions. So please, if you have to know anything about the PCR, you have to know this, okay? One thing about the amniotic fluid diagnosis, detection of the DNA, you shouldn't do amniocentesis while there is active skin lesions on the mother, because the baby may have nothing and you just transmit the infection by your needle from active skin lesion to the baby. So you have to keep in mind never to do amniocentesis while she's having active skin lesions, and you have to discuss with the mother about this. You can't deny it, you have to discuss about this, and you have to keep in mind that this test is having high sensitivity and low specificity. And they found also this in the studies. I know it's a depressing word, it's not a good one, I don't like it. That the combination between the amniotic fluid PCR and the ultrasound together, okay, having a good negative predictive value, okay, but they have poor positive predictive value, okay. Positive predictive value is poor and the negative predictive value is good. Means that if both tests say no, it's no, okay. But the positive predictive value, one of the tests or maybe both, say that the baby is having varicella infection, but it comes negative. I will explain more. In the ultrasound scanning, they found some fetal calcification, tissue calcification, and they diagnosed it as varicella infection. And later on, after this baby's born, they found they didn't have. So the ultrasound may spot abnormality and they diagnose it as varicella infection, but indeed when the baby born, nothing. He was negative for varicella. That's the meaning of poor positive predictive. Okay. Also, you have to arrange for referral to the fetal medicine specialist at 16 to 20 weeks, or as we said, 5 weeks after the infection for discussion and detailed ultrasound examination. So by any means, ultrasound examination to detect fetal varicella is at least 5 weeks later after the maternal infection. Okay. Also, one question here, can the complications of chickenpox, fetal complication of chickenpox, can be prevented? Okay, this is case study you can go through, but the point to say here is there is evidence supports that the use of varicella zoster immunoglobulin to prevent fetal varicella syndrome, okay, is positive. So they said that the mothers who took varicella zoster immunoglobulin, once they spotted they have infection, they have exposed to infection, okay, this prevented fetal varicella syndrome to happen. But they said that it's an observational, okay, it's not there is no supportive evidence, very well, but it's observational and may be subjected to reporting bias. But still, if you have in the question, they stated something regarding the varicella zoster immunoglobulin to the mother. If she took it on exposure, does it decrease the incidence of fetal varicella? Yes, they said it will help, because in this study, if you go through that 0 from 142 babies of the woman, okay, who developed varicella and they receive the varicella zoster immunoglobulin, zero suffered from fetal varicella syndrome. And those who didn't receive the immunoglobulin, it's 14, okay, out of 498, or percentage 2.8% developed varicella, fetal varicella syndrome. So yes, it helps to prevent, okay. The other thing that that is spot of, and it have much information, also the neonatal implication. So we have implications on the mother: pneumonia, encephalitis, hepatitis, death. We have implication on the in the fetal implication, which is fetal varicella syndrome, and we have implications on the neonate, the newborn. Okay, the newborn, we call it congenital varicella. It's old name, or varicella infection in the newborn, congenital varicella syndrome. It's not congenital. Neonatal, no, just it's not the right one. This should be congenital with the fetal varicella. Okay, so the varicella infection of the newborn, it comes from the maternal infection near the time of delivery. If the mother catches the infection near the term or immediately postpartum, okay, even from contact from the mother, the baby will get the infection from the mother, or in contact with any other one within 7 days after the delivery, whether he contact with some stranger with shingles, with chickenpox, whatever. So the neonatal may be from the mother, if the mother get the infection before the term, usually 7 days before delivery or 7 days after birth, or from any other person other than the mother with shingles or with a chickenpox. So how the neonate will catch the infection is called transplacental ascending infection, or direct contact with lesions during or after delivery from the mother or from any other person other than the mother. Okay, if this happens, up to 50% of the babies will get infected. Okay, if the maternal infection occurs 1 to 4 weeks before delivery, 1 to 4 weeks before delivery, up to 50% of the babies will get infected. Okay, and 23 of them will develop clinical varicella infection. Clinic varicella infection. Okay, and those will develop severe chickenpox infection when the window, the time window is within, if the infant born 7 days of the onset of the mother's rash, or the mother developed the rash 7 days after. So the severe chickenpox happen 7 before, 7 after. If the mother get the rash 7 days before delivery, or she developed rash within 7 days after the delivery. Why this? Why the baby will develop severe chickenpox in this time? Because the transmitted immunity from the mother to the baby, it will be low. There is no time to transmit the IgGs from the mother immunity to the fetus. That's why if the infection of the mother, the rash happens 7 days before delivery or 7 days after delivery, the baby mostly to develop severe chickenpox infection. Okay. One thing I want to tell you, in this guideline, in the Rcbi guideline, they stated clearly this management of the newborn beyond the scope of this guideline. So according to Rcbi guideline, you are not obliged to know these things I'm going to tell you, because this is Rcog recommendation regarding the management of the newborn. But in Rcbi, they stated clearly management of the newborn beyond the scope of these guidelines. It's not your job here. But according to Rcog, we have some points you have to know if you are going to MRCOG, or you can omit if you are not. I'll just read for your interest. They said that neonatal examination or neonatal ophthalmic examination should be arranged after birth. Okay. Neonatal blood should be sent for varicella zoster IgM and a follow-up sample after 7 months for IgG. And the neonate should be given varicella zoster immunoglobulin if the birth occurs 7 days after the appearance of the maternal rash, or the mother developed rash within 7 days after delivery, or the patient or the baby is known to be non-immune and he has been exposed to shingles or chickenpox from another source other than the maternal, okay, in the first 7 days in the life. Okay, and they stated that, as we know, no use of varicella immunoglobulin once the disease has developed. Okay, there is no rule. Also, they stated that you have to monitor the baby until 28 days after the onset of maternal infection, and the neonatal infection should be treated with acyclovir following discussion with neonatologist. As I told you, this is not stated in the Rcbi guideline. It's just recommended by the Rcog. Okay. Okay, this is always old repeated neonatologist. We have discussed this before. You can go through it. Okay, we come now to the most important part, the management of the woman with chickenpox in pregnancy. Here you have to separate two cases from each other in order not to confuse yourself. If the patient came to you and she says, I have been exposed to infection, but she's not yet developed symptoms, or the patient came to you with rash, with clinical manifestations of the disease. Okay, number one, if the patient came to you, she had been exposed, so you have to fulfill certain points. We are going to diagram to make it easy, and then you can go through this. Okay, this is the diagram in the Rcbi guideline. The management of chickenpox exposure in the pregnancy. Okay, we have to ask here about certain points. Is her contact with a chickenpox is significant or not? Because some patients just worried because, oh, some of her neighbor had shingles, like thoracic shingles or whatever, and she crossed over the door 2 days ago. You have to ask about exposure. She's exposed to significant infection or not. First, is it the chickenpox or is it herpes zoster? And if it's herpes zoster, it's exposed one, it was like ophthalmic one, or in non-exposed area, because infection from exposed area is more to happen from non-exposed area. As we know, the virus is in the fluid, which in the vesicles. So if the vesicle is in exposed place, yes, this is significant one. If it's not exposed, so we will see the other factors. Okay. If she's immunocompromised, if she's having any immunosuppressants for certain health condition, if she's diabetic like this, she's immunocompromised or not, and we should ask her when she had been exposed. Okay, does the one who have the infection, she came in contact while he is in the infectivity period or not? Because the chickenpox, it's not infectious all the go. You have to spot, does this exposure happen during the infectivity period within 48 hours of the rash onset or before the lesions have been crusted over? Okay, and how close she is with this contact. As I told you, not the neighbor next door, while she's crossing the door, she see. It's not like this. The patient have to have significant exposure. This means she was in the same room more than 15 minutes like a teacher, okay, or she had face-to-face contact more than 5 minutes like mother and her child. This what we define as significant exposure. So you have to ask about this before you put your patient on a fire. Okay. The next part is susceptibility to chickenpox. As we told at booking, we have to check immunity by history. If she have certain history of chickenpox or shingles, so reassure the patient you have the antibodies. Don't worry about this. If she doesn't have certain history, or if she is from tropical or subtropical country, you have to spot if she's immune or not. So what we are going to do, we are going to check for varicella IgG in her booking serum. Okay, we will spot from her booking serum. Okay, or it's stated that also you can take blood sample from her. Okay, in blood, that means in blood or booking serum. Booking serum, this is the stored one. In blood, you can take blood sample from her. I think it's 24 to 48 hours after exposure. You can check also for her blood to see if she's having varicella antibodies or not. If she have antibodies, reassure. Okay, but if she doesn't have and she's negative for IgG, so you have to give her varicella zoster immunoglobulin, ideally or better within 96 hours, but we still can give it up to 10 days. Okay, because why? We still it have some benefit and it helps to prevent fetal varicella syndrome, as we told before. Okay, and you have to explain to her that the immunoglobulin, the varicella zoster immunoglobulin, it can attenuate, it can weaken the infection, but she may still get chickenpox and she stays potentially infective from 8 to 28 days. Okay, post varicella zoster immunoglobulin. This is a single best answer. You have to give her the advice that the immunoglobulin can attenuate, but it may not prevent, and she's still potentially infective from 8 to 28 days after the immunoglobulin. Okay, and you have to instruct your patient, please, you should receive your vaccination in the postnatal period to avoid such incidents to happen once again. Okay, so what if this patient came to you late, or you give the immunoglobulin and the patient developed the disease, and it could happen, okay, because the immunoglobulin still infection can happen with it. It's not 100% guarantee that you will take it, you will not get the disease. It helps us, but there is no guarantee. You have to instruct your patient. So now your patient's coming for you while she's having chickenpox clinical manifestation, which is number one, the rash. The rash. Okay, it's recommended that any patient who developed rash, okay, she should immediately contact her GP or maternity hospital, okay, to inform about the infection and let them manage. Now we are in active disease, okay. If we're still uncertain about if she came to your hospital, she came to your clinic, you are not certain if this is chickenpox rash or what, so you have to go for the sample from the vesicle. You have to take swab from the vesicular fluid for the PCR, okay, and check the serum for IgG and IgM antibodies. Any patient came to hospital, okay, you have to take swab from the vesicle if you are not certain about the infection, okay, and check for varicella zoster, IgG and IgM. Okay, and what else we are going to do for this patient? If the patient have some risk factor to develop, okay, to develop varicella infection, what are these risk factors? The patient is immunocompromised, number one, immunocompromised patient, diabetic patient, patient on corticosteroid for certain lesions, patient on some kind of chemotherapy for certain condition she had while she's pregnant. This is an immunocompromised patient. We have lupus patients who have certain medications that alter their immunity. Okay, so she's immunocompromised, she's on steroids, she's smoking, cigarette smoker, or she's having chronic lung disease like COPD or whatever. These are risk factors for the patient to develop severe infection of the chickenpox. Okay, if she does have this, directly to the hospital for assessment, MDT team, and this patient we will start for her IV acyclovir directly. But if the patient she came with rash, but she has no risk factor, she's fit and well, she doesn't have anything apart from this chickenpox infection, you have to instruct her to avoid contact with all susceptible individuals, okay, until her vesicles crossed over, the infectivity period passed, okay. You instruct her for local hygiene to avoid secondary infections of the lesions. You have to give her symptomatic treatment. If she's feverish, give her paracetamol, hydration, like this. Okay, so what if this patient came to you after 24 hours of the rash appearance? Here we have to categorize our patients because we are going to select whose patient is fit for acyclovir treatment and whose patient we can't give for her acyclovir. We give acyclovir for patients who presented to you with rash developed less than 24 hours, okay, and the patient is more than 20 weeks pregnant, more than 20 weeks pregnant. You will give her acyclovir 800 5 times daily for 7 days, okay, and this is oral. The IV acyclovir for severe disease with immunocompromised patient who developed complications, okay. So you are going to give your patient acyclovir when, and it will attenuate the severity of the disease. We have to give it if the patient presented to you with the rash, which is less than 24 hours, she's pregnant more than 20 weeks, okay. So what if the patient having rash less than 1 day and she's less than 20 weeks? Are you going to give her acyclovir? Here you have to discuss with the patient, okay, the benefits and risks of having acyclovir, but you have to consider the treatment. It's on your plan, okay? You have to discuss with the patient, and if she agreed about the benefits and the risks, you can give it to the patient. Okay. If more than 24 hours, here acyclovir we are not going to give. If it's more than 24 hours after appearance of the rash, you are not going to give acyclovir. Okay, so you have to warn the mother about the signs and symptoms of severe chickenpox. Okay, what severe chickenpox we mean here? We mean signs and symptoms of pneumonia, hepatitis, like this. And you have to count here about the risk of the fetal varicella syndrome, and you have to state it's 1% fetal varicella syndrome. It's 1%. Okay, if the rash occurs less than 28 weeks. And also you have to reassure this mother and arrange for referral to the fetal medicine service and arrange for ultrasound. You have to give her full bundle of care. Okay, this is the management. This is the management of those patients who are not critically ill. The critically ill patient, we will go for IV acyclovir, IV acyclovir. Those patients who have these signs and symptoms of severe chicken pox, who have hemorrhagic rash or dense rash, mucosal lesion, who entered respiratory distress and difficulty breathing, who have neurological symptoms, which mean they have started encephalitis, like photophobia, seizures, or drowsiness. Those people, you should admit. No rule of community care here. You have to admit in the hospital, swab to confirm the infection and to exclude if there is any secondary bacterial infection or not. We are going to isolate them with airborne precautions. Okay, you are going to treat with intravenous acyclovir. So intravenous acyclovir is spared for patients who have severe chickenpox with these symptoms, and the oral one with those who have the rash. Okay, still within 24 hours, and if she is more than 20 weeks, give it. If she's less than 20 weeks, discuss and consider the treatment with the patient. Okay, here they stated we are going to add antibiotics to avoid bacterial infections to happen. And MDTT management is a must. You have to discuss with microbiology or infectious disease. And if the patient is due to deliver very soon, you have to defer her delivery until 6 days post-rash, if possible, because some patients may have obstetric emergencies. This delay may affect the outcome of her pregnancy, so you have first to consider the fetal and maternal conditions or comorbidities, and then if you can defer the delivery 7 days post the rash, it's fine. If you can't, you have to follow the other emergencies. So what we have here in the management, I think it's finished, it's done, but I would like to repeat again the management. Okay, if anyone want to participate, we are going to revise together the management part, which is the most important one in the clinical scenarios, and then we are going to take some examples, single best answer examples. Okay, anyone want to participate? Hello people, seems you are sleeping. Hello, anybody here?
Yeah, we are here, Doctor, but we join you late.
Okay, so we can go to the single best answers and then we can revise if you wish. Okay,
Yeah, one
anybody
time we
interested?
will revise.
Yeah, exactly, management.
Okay, so we are going to start single best answer and then if we have a chance, we are going to explain again the management part. Okay, who's gonna participate with me, please? Hello.
Okay, I will take, Doctor.
Okay, you are welcome, dear.
Okay.
You can start.
29 years old woman, bar 1 plus 2, who came from country is developing where just had an emergency cesarean section for failure to progress. She was not sure if she had a past varicella zoster virus infection. She has been tested and found to be non-immune. She requests a postpartum vaccination. What is your advice regarding breastfeeding? Cesarean
Okay.
section. Cesarean section delivery is contraindication for postpartum vaccination. No, she had not breastfeed because the vaccine is a live attenuated vaccine. There is no benefit in vaccination because she had already delivered. She found formula uh, feed for the first 4 weeks. It is safe to breastfeed.
Okay, what's your answer, doctor? Okay, let's
Should
go. Yeah. You just pick one and then we will discuss, no worries.
D. I will select D.
B, she should not breastfeed because vaccine is live attenuated vaccine. Okay. I have stated this clearly that varicella zoster vaccine is not a contraindication for breastfeeding. It's safe. It's completely safe. Okay, to continue breastfeeding after she took her vaccination. And they stated also something, if the patient is having varicella zoster
Varicella
infection,
zoster.
okay, if she had the infection but she doesn't have active lesion near the breast or the nipple area, she can breastfeed. And if she have lesions near this area, she should express her milk and give it to the baby. So it's completely safe, and this is a single bit answer question, which is repeated. Yes, it's safe
Should
to
be
breastfeed, yeah, after she got the vaccination, or even if she had the infection, but there is no active lesions near the nipple. Okay?
So answer will be E.
Yeah, right. Okay, anyone else, please?
Dr. Walaa, but it is live attenuated, right?
Yes, right.
So we can breastfeed, Yani.
Yeah, you can. It doesn't affect the baby. It doesn't affect the baby. It doesn't express in the breast milk. The only thing we fear about here is that the baby, if she have active infection and she have rash, active rash, and it's near her nipple, the vesicular fluid may affect the baby. That's why if she have active infection near the nipple, she can express milk and give it to the baby. Whatever. Okay?
معلش دكتور ولا
Yeah.
for how if patient had active infection, for how long we will ask the mother to stop breastfeeding? يعني just all express the milk.
For the infectivity period till the vesicles completely crossed over, which is nearly about 5 days. Okay, but if she have active lesions near the nipple, she shouldn't put the baby in contact with her breast until all these lesions crossed over completely. Okay.
Okay, thank you.
You're welcome. Okay, next question, please. Hello, next question.
Can I share, Dr. Walaa?
Yeah, sure, dear.
The GP phone knew about 27 years old Egyptian woman who is 23 weeks pregnant and has developed mild sign and symptom of chickenpox in the last 24 hours. He
Yeah.
wants to know what treatment he should offer her. What advice will you give him? Offer her oral administration of 500 milligram acyclovir 5 times a day for 7 days. Oral acyclovir administration only if her condition worse. Send her to hospital to receive Varicella Zoster Immunoglobulin, start both antiviral therapy and Varicella Zoster Immunoglobulin, start Varicella vaccination. It is we will give her acyclovir, no chance for immunoglobulin.
Okay, let me explain this part because some ask about the management. Let us spot this. The patient is 23 weeks, so she's more than 20 weeks, and she have already developed mild signs and symptoms. So mild signs and symptoms developed, no need here or no benefit from the immunoglobulin. You are not going to give her immunoglobulin. Okay, and he said that the symptoms in the last 24 hours. So this patient is a perfect candidate to take the acyclovir treatment, and this is the right dose. It's 800 mg 5 times for 7 days. So the right answer is A. Okay. Okay, next question, please. Okay, we don't have much questions, guys. Please be active.
Okay, I will do, doctor.
Okay,
Question
dear.
number, okay. 22 years old teacher, gravida 1 para 0, was given varicella zoster immunoglobulin after a significant exposure to chickenpox at 25 weeks of gestation. As she was found to be a seronegative on the booking bloods, how long should she be considered potentially infectious after exposure to chickenpox? It should be 8 to 28 days C.
Yes, right, because taking the immunoglobulin will extend her infectivity period to 8 to 28, and we state this clearly.
Yeah,
Okay,
clearly in the lecture. Thank you.
yeah, you are welcome. And this is our last question. Who's volunteering?
I will continue.
Okay, sure, you can.
Okay, a midwife contacts the antenatal clinic regarding a 21-week pregnant woman who was seen in the community center. The woman is worried because her 5-year-old son developed a rash 1 day before. The woman cannot remember having had chickenpox herself. What is your advice regarding her further management? Because she doesn't remember this thing, so what we can do, we can do for her the blood test to see
Okay, right.
if she has got yeah. Tell the
Yes.
midwife to reassure the patient that potentially susceptible individuals are not at a risk of infection once the rash develops. Therefore, no further management is required. No. If patient is not immune to varicella zoster virus, she should be given immunoglobulin. No. Patient should attend her local community center for a blood test for varicella zoster virus immunoglobulin, IgM. Call the patient in for blood test for varicella zoster virus. I think it should be C, Center for the blood test for our IgG, IgM.
Yeah, we test the patient usually for immunity for IgG. Okay,
Yeah.
so I would say
B.
I will call the patient, okay, for the blood test for varicella zoster virus. You have to check. No, sorry, it's not the varicella zoster virus. Okay, because we didn't develop any rash. Varicella zoster virus, it is a swab from the vesicles, so it's not this one. And here I think we should check
IgM.
the
Wrong also.
IgG. It's not the
IgG.
IgM. The IgG patient attend local community center for blood test for IgG to check she's immune or not.
Yeah.
Please answer, Shirley.
Okay.
C should
Okay.
be answered.
Dr. Walaa, answer B also seem right.
Okay, dear, let's check. If the patient is not immune to varicella zoster virus, she
Yeah,
should be
this is
given
also right.
varicella zoster immunoglobulin. And let's check the question once again. The woman worried about, okay, rash developed one day. Okay. This is
No,
also right.
doctor. No, doctor. According to question, C is the best. B is best if the result will come.
Be asking about your further management. Number one, you have
C.
to check for the immunity.
Yes.
The start is to check for the immunity. After that, if she's not immune, you will go for the immunoglobulin. But this is step number one. Both are right. Both right.
Step 1. Yeah.
Okay. But number one, we have to check her immunity status, as she doesn't have solid history. She doesn't know she's infected before or she have immunity or not. So we check first for the immunoglobulins. And after that, if she's not immune, we will go to the immunoglobulin. Both are right, but we have to check this first.
Step 1 is C. Step after the result is B.
Yeah. Okay, guys, I'm going to put this summary on the group. If you okay. Okay, I'm going to put this summary on the group. I wish during this period till we prepare for the next guidelines, I'm going to arrange for 2 guidelines in one session next time. Mostly I will send you which guidelines we are going through. If any one of you have questions regarding this guideline, please send on the group for discussion. I wish you go through this, especially the part with the diagrams. There is no much differences between the GTG and this one. Only this part with the green I wrote here is extra from the RCOG guidelines. It's up to you to go through it. I prefer to cover my back to go through it just to know. But as I told you, it's stated clearly, and you can go and check this in the guideline, that the management of newborn is beyond the scope of this guideline. So it's not your job here. If he's going to ask you about clinical scenarios regarding the items we have covered, maternal implication, fetal implication, management. I put some basics here just in case it come as a single best answer, one option or something, so you just cover your back. And this is also stated in the guideline. This basic part is stated in the guideline. The numbers are not much different between here and there, just here 90%, here 85%, here 10 to 14, and the other one is 10%. You will go through. I just stated the differences near here, as you see. This is the Irish one, the UK one says like this, so you can know and spot what is differences between this one and those one, especially for those people who are studying for MRCOG and now thinking to make benefit of the time lag between the examinations and go for MRCPI. Okay, thank you so much. I hope you find it beneficial for you, and I hope
Dr. Walaa.
you are welcome, my dear. Hope to see you next time. If any questions,
Dr.
please send
Walaa,
to the group.
please kindly tell us when is your next class.
Thank you.
I'm going to
Doctor, in UK, sorry, it was
yes, dear.
it was the complication in UK. It is written 1 in 200. It is 1 in 2000 in you according to UK.
1 in 200.
1 in
I think in
200.
this first page.
And I may revise it, but it's in Irish. I'm sure it's
200 or 2000.
100, 1000, not 100. Just 1 minute. The Irish guidelines did this 3 in
You put 1 in 3,000, I think.
3 in 1,000.
In 1,000.
Yeah.
Wow.
3 in
Okay.
1,000. Okay.
Okay.
So if you just put the
Thank you.
fractions, you will find it near.
Doctor,
It's
you
not
can
that
provide
far.
us with PDF for this lecture. Nice lecture. Yeah.
Okay. But it is just formulated in a different way. Okay.
Okay.
So if any questions, please send
Dr.
on
Jazakallah
the group.
khairan.
Okay. Nice to have you today.
We need
And
PDF for this nice lecture, Doctor.
you are welcome, my dear. I hope you find it beneficial for you. And I just wanted to spot the differences. It's not that pretty much, but you have to know it. Okay.
Yeah.
Okay. See you next lecture. I'm going to send. I need to arrange some things because my kids are still not going to the school, so I have to arrange for someone to sit with them during the lecture. So I will send, but it will be in a week duration. It will not be too far. Maybe after a few days, I will state this on the group and tell you which guidelines we are going through. But I'm arranging to take 2 guidelines next time to just make it going fast. Okay. And for those who have, I think someone sent me a message. He or she's going to September Rcbi examination. So I think she can